My name is Soo Park. I'm a medical oncologist at the University of California in San Diego. So in 2022, we've seen a lot of practice-changing updates in melanoma, and I think one of the things that really stands out is now we know the best sequence for therapies in frontline metastatic melanoma patients who are BRAF mutated. And so the DREAMseq trial told us that for those patients, they are better served by receiving frontline immune therapy over frontline targeted therapy with significant improvements in overall survival at 2 and 3 years. But there was a subset of patients that did die early with immune therapy, and we're still trying to figure out, what exactly happened to those patients. And we know that difficulties with crossing over to the other arm was a factor, but perhaps there are other biologic factors that we should take into special consideration. And for those patients, perhaps they would benefit more from a sandwich approach, such that which is currently being studied in the Succumbit trial. That I also discussed was the role of triple therapy, and that is typically with a PD-1 with BRAF MEK. And given that triple therapy has only shown to improve progression-free survival in one study, and with 2 other studies showing no improvement, I think we should not really use this type of treatment up front until we have more data on how best to sequence those therapies, or until we have more biomarker data that helps us determine which of those patients would best benefit from triple therapy. So in practice, patients who are BRAF V600 mutated or not mutated who have advanced melanoma should receive immune therapy up front over targeted therapy. I think the most important thing that we've learned from the treatment of advanced melanoma is sequencing of the therapies. There may be a lot of practitioners who are giving BRAF targeted therapies up front for BRAF mutated patients, but really they should be getting upfront immune therapy. And as we've seen in the DREAMseq trial, this leads to improvements in overall survival that are quite significant. When we treat with BRAF up front, almost all of those patients do develop resistance, although the response tends to be rapid. So the practice-changing guideline now for all patients in the frontline space, regardless of BRAF mutation status, is to receive immune therapy with ipilimumab at a dose of 3 mg per kg with nivolumab at 1 mg per kg.